Welcome to Population Health Information Technology, bringing it all together. This session will take approximately 20 minutes to view and is the fourth and final session of this series. We'll cover two use cases that bring together the topics of what we've learned in the first three sessions. Our objectives in this fourth and final session are to assemble what you've learned in the previous three sessions through the presentation of two use case studies showing how clinical workflow and processes can be supported with technologies that we've covered in this series. We'll demonstrate how data insights and discoveries translate into excellent healthcare to the communities and populations, as well as individuals you serve in the context of a value-based care system. We will also talk about next steps to move forward with population health information technology. Here is a list of the many acronyms and terms we are using in this series. Please pause on this slide if you need to review any of these. These terms were reviewed and defined in sessions 1 through 3 of this series. Reviewing the information shared in the previous sessions, the first session covered the broader, high-level concepts of population health management and how technology can support value-based payment systems and models. The second session went into more detail on data sources and collection, data analytics and stratification, and data utilization. Session 3 provided various examples of health information technology being used in direct patient care and how the data can be translated into actionable knowledge to drive care in many settings. We've been focusing on the use of technology to support improved population health, but technology is only useful if it's incorporated into organizational processes and workflows. Using the technologies we have covered in this series, we can collect data, analyze it, and use it for targeted interventions to provide health and wellness care that can and will improve outcomes. Furthermore, we can identify and target those who need the care and services the most. These data-driven and technology-enhanced practices will become the new normal, and each organization, based upon their population, available resources, and technologies, will develop and document new standard operating procedures to assure consistency in results. For effective value-based care workflows that support improvement in population health, it will be important for organizations to develop partnerships and community referral processes with local agencies to address the needs most prevalent in their population and begin to build a medical neighborhood. Forming clinical and non-clinical partnerships is a community-wide effort, most likely regional, and with remote rural locations will likely involve technology. The first use case will present how one rural health clinic uses technology and data to improve the care of community members, focusing on improving the rate of completed annual wellness visits. The following use case is a fictional but not unrealistic expectation about how a small rural clinic manages their patients' Medicare annual wellness visits under value-based care. We have created this scenario as it is happening across the U.S. already where health information exchange is prevalent. Although we've been focused on health IT tools, the interaction between tools, people, and processes is important. And sometimes the telephone for outreach to patients is one of your most effective tools, particularly if you have the data to help target appropriate patients and the designated staff time and role to do the outreach. You likely already have some of these tools, so use what you have, or what your patients have, such as the ability to use patient portals and features of that in their smartphones to maximize their potential. The technology capabilities we'll describe in this use case were not implemented all at once. The healthcare facility and its staff made incremental improvements and were provided training on the use of data tools and workflow development since joining their ACO in 2019. In our first use case, Mountain Peak Clinic has protocols in place to improve the completion and effectiveness of annual wellness visits after a significant decline over the past 2 years of the pandemic. Despite struggling with returning to normal staffing and activities, the clinic does have everything in place for making these improvements. Try to imagine how you can embed any of the strategies described in your organization's workflow. As you can see by the SMART goal here, a goal that is specific, measurable, achievable, relevant, and time-bound, the clinic aims to improve the rate of annual wellness visits to 70% by the end of this year. Prior to the pandemic, the clinic was sustaining an annual wellness visit rate of about 38%, so although it is a significant jump, clinic staff thought it was feasible. We'll show you how the clinic collects, analyzes, and stratifies data from their EHR to improve the quality measures put forth by the alternative care organization they recently joined. This is their first year of measuring, and increasing the percentage of patients receiving their Medicare annual wellness visits through targeted actions to drive change using their EHR supplemented by a population health software application provided by the ACO. Mountain Peak Clinic involved representatives from a number of different roles and departments on their team for this QI project, representing all areas that would be involved and interested in the work. They included the RN, clinic manager, nurse practitioner, medical assistant, and office manager and receptionist. The office manager, NP, and RN set up the needed reports with some help from their EHR vendor, and the medical assistant and receptionist performed many of the routine tasks, such as sending emails and letters to patients reminding them of appointments and verifying demographics when patients call in. The first step in attaining their goal is data collection. They started with data collection via an EHR-generated report on the number of annual wellness visits in the current patient population. They developed parameters to create a report, tweaking it until it performed as required. They stratified their data by payer type, patient age, and date of the patient's last annual wellness visit, running 3 separate time frames of the past 12 months, 18 months, and 24 months. From this report, they identified the percentage of patients with no annual Medicare exam and the date of their last recorded annual wellness visit. Although in this example we're discussing annual wellness visits, similar EHR reports could be run to look at other preventive services, such as depression or cancer screening, or immunizations, or looking at health indicators such as A1C for individuals with diabetes. After scrubbing the data for accuracy, they analyzed it to assure they were targeting the correct population. They could then identify and prioritize their target population. As part of the identification process, they were trained how to check the Health Information Exchange system to see if anyone on the list was seen at another clinic within their state and region, which included surrounding states. After removing several names from the patient list based on services received elsewhere, they started prioritizing. Their priority list included any Medicare-eligible clients who had not received a wellness exam at any facility in the past 2 or more years. Using the ACO-provided population health risk stratification tool, the list was stratified by race and diagnosis, targeting additional diagnosis of heart disease, diabetes, and COPD. The initial list of overdue exams totaled 218 patients overdue for their annual wellness visit. After stratification, identifying the highest priority patients, the list was narrowed to 24 patients. They were now ready to begin utilizing the data by reaching out to high-priority patients. The quality improvement team decided they needed to revisit their processes and workflows to increase efficiency and improve their annual wellness visit rate. Mountain Peak Clinic started with workflow analysis and redesign. Their entire staff met and documented their current workflows and did some brainstorming to redesign their desired workflows and agreed on the best process to meet all of the required steps for a Medicare wellness exam. Everyone discussed what things needed to be in place for successful outcomes and excellent patient experiences, including how their individual roles and tasks for annual wellness visits would change. Using a plan, do, study, act (PDSA) approach, the team tested and then implemented the desired changes to workflow, then monitored progress and continued to make adjustments as needed. If your team needs to brush up on your quality improvement, Stratus Health has a free online curriculum available that focuses on QI basics, including workflow process mapping and templates to support PDSA cycles for implementation. There is a link in the resources slide at the end to access this. After calling the first 24 individuals on the patient list, the clinic followed up with letters for those they were unable to reach, and also conducted appointment reminder calls or sent texts, depending on patient preferences. They then moved on to the next prioritized list, and continued until all patients were notified, putting a 3-time attempt rule for contacting patients by at least 2 methods. They also ensured that an annual wellness visit reminder was posted in the EHR portal for all prioritized patients. The EHR vendor-initiated dashboards were shared with clinicians to monitor the percentage of wellness visits completed by individual providers, and clinicians were delighted to see real-time results. It also alerted them if a patient being seen for another reason was due for an annual wellness visit. Recall that as we move closer to real-time data collection and use, we are moving into the proactive realm of healthcare and away from the historical, reactive approach. The office manager initially ran reports weekly, then monthly as numbers improved. Within the first 2 months, their rate already jumped to 65%, and they adjusted tasks that were creating bottlenecks in the workflow. You can see that ongoing monitoring of results is vital to continue the efforts toward your quality improvement goals. Once targets are achieved, the frequency of monitoring can decrease, but if rates decline, the care coordinator, who oversees this process, will need to work with your team to understand why, what barriers they might be facing, and then interventions and workflow changes may be needed to address barriers for staff and patients. The second use case will address how Mountain Peak Clinic uses population health information technology in the value-based care environment to improve individual health outcomes. Mountain Peak Clinic reports data to their ACO on several measures, including hemoglobin A1C. They have identified diabetes as an area of concern in their patient population. As part of their engagement in the ACO, the clinic has hired a social worker to serve as the clinic's care coordinator, including responsibilities to follow up directly with prioritized or eligible patients and develop local partnerships and referral networks to help patients address non-medical or social needs that are impacting their health. In particular, they are focusing on patients with a hemoglobin A1C greater than 9. They use data collection, analysis, and stratification methods and are now at the data utilization phase. The EHR generates a patient list or registry of patients with diabetes who are at higher risk of complications. Harlow is on the list because he had an elevated hemoglobin A1C on his last visit. Think of data elements you might want to include on the list, for example, basic patient info and demographics, payer, lab results, and dates, diagnoses, provider, or other information needed to be useful to your team. The first step to use the data to work towards providing excellent care for patients is for the clinic RN to review Harlow's records in the EHR. She finds that in addition to type 2 diabetes, he also has diagnosis of hypertension and obesity. He was last seen 2 years ago for his annual wellness visit. Several notes in his charts related to missed appointments, and the cause of those was largely related to lack of transportation and COVID restrictions. On further review, the nurse notes he obtained medication refills by phone over the past 2 years. After reviewing his records in the EHR, the nurse calls Harlow. She discovers he is generally doing well and has no COVID symptoms. He is checking blood sugars, and they are a bit high with the last results at 155 a week ago. Prior to the pandemic, he had been seen by a primary care provider once a year, but unable to commit to making an appointment at this time due to a lack of transportation. During the call, the nurse is alerted to several social issues that could impact Harlow's health negatively. She starts asking more questions to learn about any social and economic challenges, concerns relating to social determinants of health, to assure the clinical team supports a holistic approach to Harlow's well-being. Data elements around social determinants of health are now more frequently included in healthcare assessment tools. During the call, the nurse discovers Harlow is a retired construction worker who lives alone in a rural area, and he is unable to make an appointment because his car is not working. He has no transportation or other way to get to the clinic. He also needs his medications for diabetes refilled. After identifying the transportation issues, the nurse arranges a telehealth call later that day with a clinical social worker or care coordinator. She also requests medication refills from the provider for the local pharmacy to mail to Harlow. The clinic's social worker held a video call with Harlow on his cell phone. She already knows that Harlow is a 68-year-old retired construction worker who lives alone in a rural area and is unable to make an appointment because of his transportation issues. Upon further questions using the SDOH tool in their EHR, a series of questions with a screen available to capture the responses, she discovers and documents additional information about Harlow. He is very intelligent but has low literacy. He is recently widowed with limited family support. Harlow has 4 adult children, and his daughter visits him weekly and shops for him. Also, he is on a general diet, but doesn't eat a lot of fresh fruit or vegetables, and does not walk outdoors because, as a minority in a rural community, he states that he doesn't feel safe due to hate crimes in the area. He admits having high anxiety and past trauma in his life causing anxiety. He uses alcohol and marijuana a couple times a week. He has stable housing, running water, and generally feels safe inside his home. While Harlow was on the telephone call, the social worker accessed the Community Information Exchange system that had been implemented with local and regional resources to locate and secure transportation options. Harlow agreed to use the transportation arranged and to see a nurse practitioner in 3 days, so an appointment was scheduled. The second intervention was to add Harlow to the care coordinator program due to his having diabetes and because of other SDOH risk factors, assuring he has access to needed healthcare visits and preventive care and other resources that could help him meet health goals. If your community isn't to the point of having a community information exchange available, these processes can be replicated using non-IT enabled supports. Development of community relationships and an understanding of what resources are available locally, even if that list is on paper, is a critical step in better meeting patient needs as part of the shift to value-based care. The technology is simply a tool that can make those processes more timely and efficient. This slide shows the intersection of health IT with some other options for Harlow or patients like him that can and should be accessed by the healthcare organizations providing care for patients who are at higher risk of poor outcomes. Health information exchange, community information exchange, telehealth, and telemonitoring are tools that can be implemented to better support care coordination, identification, and referral to services and resources. As you redesign workflow processes that identify social needs and disparities or other risk factors that impact your patients, it is incumbent on your organization to work with your communities to identify community resources and work with your team to implement referral processes to address social needs. Like many technologies that we have covered, there are possibilities and solutions to further automate the processes to create more efficient workflows, but again, these start with relationships, building trust with our community partners, and then seeking out technology solutions to make them more efficient for all concerned. These use cases describe ways rural hospitals and clinics are already using healthcare information technology to support population health and are not beyond the stretch of the imagination. We ask you to dream big and prepare for your journey in value-based care. We hope that these sessions and the use case descriptions have been helpful for your organization in understanding the variety of technology supports available and the opportunities for their use in supporting population health and value-based care. As you consider next steps, we want to make you aware of resources made available by the Rural Health Value Team, which is also supported by Stratus Health. The Guide to Selecting Population Health Management Technologies for Rural Care Delivery, which is linked in the Resources section, helps rural organizations walk through a 6-step process to select population health-focused technologies. We encourage your organization to consider selection and implementation of software or other applications to support population health using a strategic planning process that requires input from both decision makers and from frontline clinicians and staff that will be utilizing the tools. The guide includes a variety of tools and resources that will help your organization identify and form a team, set goals, consider financing options, develop system requirements, compare products, and ultimately select a vendor and negotiate a contract. Before taking action toward an independent technology selection process, we encourage you to assess if affiliation with a larger organization or network may provide access to population health management technologies. For example, if you plan to join an ACO through an ACO aggregator or service organization, a population health management platform is likely to be one of the supports available through that engagement. As we wrap up, we encourage you to remember a couple of key concepts. First, that technology isn't a solution on its own. It takes alignment between the technology, the people, and the processes for technologies to provide a valuable return on investment. And second, shifting to value-based care and focus on population health is a journey, and healthcare IT tools can be a key support. But to move in that direction, continue to keep the mantra in mind that we have used throughout this 4-part course. Start where you are, use what you have, and do what you can. In this final and fourth session, we looked at 2 use cases for organizations actively engaged in value-based care and how technology is integrated into them to support the desired outcomes. A few resources were cited during this session, and those are available in the following resource slide. A separate PDF document is available with all the slides for this session, including the resource slide. The PDF document has hyperlinks to make the resources easy to access. You might also wish to use the PDF documents from the prior 3 sessions to access other resources and references used or mentioned in this course. Thank you for taking time to review this final session and for the time you've invested in all 4 sessions. We hope this contributes to your understanding of the information technology components of value-based care and wish you success on your own journey.